We all have energy throughout the day that is allocated to us on a daily spectrum. And if I'm wasting energy standing upright because I have a forward head posture, an anterior pelvic tilt, or a forward displacement of my center of gravity, the tension between my flexors and extensors is not balanced. So I will end up spending more energy standing upright.
Annette Verpillot, welcome to the show. I'm just thrilled to welcome you to the Better Podcast today.
Thank you so much for having me. It's a pleasure.
I'm so excited to talk about this because this was my jam for 16 years. We're talking all about posture. And I, as a clinician, had a really hard time selling posture. You know, it's like you understand, you take all the courses, you do all the neuroanatomy, you do all the things like, oh my gosh, this is totally affecting injury rates. It's totally affecting hormone production. It's totally affecting the way that we squat. I'm so excited to teach this to my patients. And my patients were like, whatever, I don't care about this. Just tell me how to squat. What's the glute thing? What's the nutrition thing? So I'm hoping together, you and I, along with the clinicians that I know listen to the show, can help to educate our beautiful Betties, my audience, on the importance of posture. So let's just start with order of operations. Like when we're thinking about posture, where do we start? I know I have teachers that have very strong opinions, like top or bottom, but I'd love to know, do you start at the head, the pupils? Do you start at the feet? And why, even before that, why do we even want to be thinking about posture? Let's start there. Why do we want to be thinking about posture, Annette?
Well, depending on where we are on the spectrum, whether we're a newborn child, a baby, a toddler, or an adult, posture begins with movement and primarily is an unconscious process. So I know that in the realm of rehabilitation, we tend to focus on the musculoskeletal system, but what dictates our posture is sensory stimulation that we receive from different sensory receptors, being visual, vestibular, and proprioceptive. So for me, posture is whether you have good synchronicity from those sensory receptors that then send signals to your brain, which will then send signals back down to your muscles in order for you to execute the commands based on the environment or the desired movement that one is looking to achieve. So I have a background in rehabilitation, and I was taught to look at muscle tone and range of motion, but it turns out when you dig a little bit into it, that muscle tone is the reflection of the brain. So if there's an asymmetry in muscle tone, we have left brain and right brain, the descending motor tracts are going to affect that respective part of the body and the muscles on that side differently. So I think that the biggest misconception is that we can train our way out of poor posture, although training does help posture because we are activating the muscular system. I rarely have seen, just with conventional training, this is excluding visual and vestibular information and proprioceptive information from the equation, I've rarely seen correction of asymmetrical muscle tone with just standard weightlifting, if I may say. So movement is life. When we stop to move, the brain kind of atrophies, and movement is what helps us develop our brain. And as you mentioned, from the bottom up, from the back to the front, ultimately the goal of, again, where we are on the spectrum, if we're talking about a newborn baby, we want to stimulate that proprioceptive system as much as possible. And if we're talking about an adult that's trying to just maintain a healthy lifestyle, it's going to become really important for all of those coaches out there to make sure that their proprioceptive system, visual, vestibular, proprioceptive muscle, joints, and skin is in check in order for us to have the best results with posture correction.
I love what you're saying here. And I actually want to just double down on the point that you cannot weight train yourself into better posture. If anything, you are reinforcing already sort of known mechanics, right? And to your point, because our posture is, as you said, it's in the visual system, it's in the vestibular system, which we're going to explore today, and in the joints, it's in the Golgi tendon organs. And this is like, I know some people are like, what the hell is she saying? So for my clinicians, you may know what a GTO is, but for a chiropractic adjustment, let's say, is a reset of the muscle spindle. This is why we see sort of a relaxation, or it actually, sometimes it feels really good because you sort of have this afferent. So as you mentioned, like the sensory is everything coming up to the brain, telling your brain where you are in space. And then there's going to be a motor efferent. So there's a descending. So the brain will say, oh, okay, based on that information, I'm going to send some information down. So this brain-based approach is actually it's like, for the nerds out there, this gets me like really lit up, because you can change in real time, with an adjustment or with some of the strategies that we're going to talk about today. You can change someone's posture, the way that they move, the access that they have to range of motion. It's like, then there's like sort of like the pre and post adjustment. At least I can speak from my own clinical experience. Like pre and post range of motion is very, very different, because we are resetting some of these neuromuscular segments, I guess if you will. So where do we start? We talked about visual, vestibular, joints. When we're doing a postural evaluation, so maybe somebody comes to see you in your clinic, or maybe, they're looking in the mirror, where do you start? And I'll preface this by saying that I've had mentors over the years who will argue to the death, one or the other. So it's like, you either start at the feet, that's where it all is, or you start at the head and the pupils. I'm curious to know, and like in the sort of vein of transparency, I would start at both, like just depending on where the patient was. If there was like a knee problem or a hip problem, I'd probably start with the feet and then kind of work my way up. If there was a shoulder problem, if there was an upper body problem, I'd probably start looking at head tilt, pupils, that kind of thing, which I'm sure if any of them are listening, I'm going to get a nasty email, but tell me, because it's very, very, like, I know that it's very charged. So tell me what you think in terms of like, where do we start? Where do you like to start generally? Do you have a preference, or is it based on what the patient is presenting with? What do you think?
Well, for the sake of simplicity, I tend to look at the way that the person is fighting gravity. Fighting gravity is the greatest indicator for me. And my intervention always targets changing the way that they are relating to gravity. Well, what I came to realize in my practice is that we all humans have these internal mechanisms that are constantly measuring and perceiving our environment to help us stabilize our body in space and to fight gravity as efficiently as possible. And I'm going to emphasize gravity being spending the least amount of energy from a cellular level, from an energy level, from a mitochondrial level, spending the least amount of energy when our muscles are upright. So it turns out there's two types of muscles, as you kind of mentioned very quickly. There's the static and the phasic. And most rehab out there tends to focus on phasic movement. But posture, which is tonic, is a succession, tonic posture, of different movements. So if you're going to work on the movement aspect, you must, if you want to be as efficient as you can be, you must look at someone's static posture, which involves the way that they are fighting gravity. I'll give you an example. We're all decaying by the minute, unfortunately, and I don't want to sound drastic, but we are all going towards from point A to point B being the end of life. And it's about how we are handling the brakes, and the acceleration will dictate how quickly we move forward to point B again being that cliff and the end of our lives. We all have a certain amount of energy allocated to energy throughout the day that is allocated to us on a daily spectrum. And if I'm wasting energy standing upright because I have a forward head posture, an anterior pelvic tilt, or a forward displacement of my center of gravity, the tension between my flexors and extensors is not balanced. So I will end up spending more energy standing upright. So where do I start? Well, it turns out that the feet and the eyes together affect this reality. Feet and eyes together. So I will always start clinically by neutralizing, meaning optimizing, removing any asymmetries with the weight-bearing surfaces. And I can actually measure this to the square millimeter because we can see pre and post interventions that are simply, again, without ever touching anyone. We're just simply stimulating the sensory input going into the brain by addressing the feet and the eyes at the same time. We are looking at the way that the postural strategies of this individual is changing. How are they relating to gravity in that moment once we have improved or optimized the sensory input going into the brain? I like to start with the foot correction first, because whatever will be left over, meaning if there's a lower shoulder or lower hip and I address the foot and all of a sudden the shoulder and the hip realigns, I know that the foot in this example was causing the imbalance in the frontal plane, tilting the shoulder to the side and the hip to the side. So whatever's left over after addressing the foot is probably caused by the eye. So now in the session, addressing the eye alongside with the foot and seeing whatever's left over, I tend to say that 8 times out of 10, if we're dealing with a healthy individual that that does not have any neurological issues, if they're athletes, which is most of my clients' children, we see really quick changes or improvements. 8 times out of 10, there's an 85% improvement in 25 minutes. I mean, I know it sounds terrible. I mean, it sounds unrealistic to say that it can happen that quickly, but that's how quick it could happen because the person has a healthy nervous system. So the information being processed by the brain is happening fluidly, it's happening quickly, there's no obstacles, and the nervous system is responding positively to these postural changes, which are really affecting their sense of balance. Because when you address the foot and the eye, what you're doing indirectly is that you're having an effect on the vestibular system. And the vestibular system is in direct connection with the cerebellum, which is going to affect everything that we're trying to correct in rehab without ever even understanding or considering the cerebellum in any types of sports or movement or rehabilitation. So it's almost like this blueprint, this unspoken of blueprint of posture correction has been created out there, and this entire system has been built on symptom management without ever understanding or even looking, which actually is really simple. Understanding the neurology is complicated, but applying it in a clinical context is so simple for anyone to do. Without having a really in-depth understanding of neurology, anyone can start working with a brain-based approach, have amazing results instantly, which is super motivating for the patient, which is super motivating for the therapist, the coach, or anyone that's really looking to improve healthcare. So I apologize. I think I've derailed from your original question, but I will start with the feet, and then alongside we'll work with the eyes, and then see how the person is fighting gravity and if there's an effect in their relationship to it.
Okay, so we're going to start with the feet then. We'll do a double click on feet and then we can move to the eyes. Just by way of definition, you mentioned the vestibular system. So for some listeners, they may have never heard that term before. This is basically a sensory system that creates balance and spatial orientation for us for the purpose of coordinating movement. Okay, so there's in the vestibular system, we have something called the semicircular canals, which are basically these horn-like structures in the head. And then you're also going to have like the inner ear, like those two things sort of communicate with each other. We don't have to get into the anatomy of the semicircular canals, but I will say what's really cool about them is that they're all sort of at 90-degree angles to each other. And there's 3 of them. So that we're looking at horizontal planes. And then if you're turning your head left and right, if you're tipping your head down and up, you're going to be activating certain canals. And then of course the inner ear is like looking at sort of maybe the velocity or like the linear acceleration, let's say, of that movement.
Love the way you just described it. I just would like to add to that for your listeners, and maybe I think hopefully it'll be insightful, is the autolytic system, which is also part of the vestibular system, the utricle and saccule, which basically will detect up and down and forward and back accelerations. That system, in comparison to the semicircular canals, is constantly 24/7 sending input to the cerebellum. Constant. You're sitting down, the autolytic system knows you're sitting. You're standing up, it's picking up on this information. You're walking, you're jogging, you're in a train, you're in a plane, whatever the context, it's constantly operating 24/7. Why is this important? Well, if you have a head tilt, for example, of course, the semicircular canals are going to be affected because the liquid will tilt in one direction as opposed to the other. But the autolytic system, always operating, is going to pick up on this information and will have a direct influence on your muscle tone, on your flexor, that tension between your flexors and extensors, which dictates upright posture. So the autolytic system is there to help us stabilize our vision in space when we're moving, but it's also there to send feedback 24/7 to the nervous system. And that's where it's going to become interesting to see how the weight-bearing surfaces are changing. Because if this reality is true, the way that your feet land and weigh themselves on the ground, the way that you're distributing your body weight on the ground will change automatically and unconsciously. And this is where you can pick up on asymmetrical weight bearing. I call it a mixed foot because 72% of the time I'll see someone that overpronates and oversupinates on one side in comparison to the other. And as we're going to get into now, this will, of course, lead to biomechanical restrictions. And this is where the whole rehab system comes in. They're looking at the biomechanical restrictions that we're talking about without kind of understanding or looking at the entire backplate system that is affecting what they're seeing clinically.
Great.
That makes
We
sense?
used to, in the clinic, we used to actually put two scales under the patient and 1 foot under one scale, 1 foot on the other, and have them look up. Like they would look down and they try to sort of like change it, like to make sure that it was even. It's like, no, you got to look at me, and then we'll take the reading that way. So when we're evaluating statically, when we're evaluating foot position, when someone is potentially seated, we would look at them seated as well as standing. What are some of the things that you're looking for? You're looking for a foot flare. You mentioned supination, pronation. What are some of the things that you are looking for as someone is seated, standing, or even in that transition from seated to standing?
Yes.
Which would be phasic, but yeah.
Well, the way I do it is standing up, unless they can't literally stand up, because I want to have the proprioceptive, the weight bearing, as well as the visual come into play. And I want to see how that individual's postural strategies, how are they managing their body in space? I'll do a couple of tests to challenge their stability. Eyes closed, for example, walking on the Romberg test, the Fukuda test, which is, walking and testing someone's sense of balance to give me a better understanding. Sitting down, I'll do the spin test to see if there is an asymmetry in movement from one side to the other, which there usually is if there is an eye imbalance.
Just explain what the spin test is for our listeners in case they're not familiar.
Yeah, absolutely. So sitting on a chair that you can spin with wheels, I will have the individual lift their leg, close their eyes. They're in a relaxed state. And I very gently just spin on one side. So basically you're sitting down, the chair is spinning for 10, 15 seconds. And when the chair stops spinning, the individual should naturally feel, once the movement has stopped, should be able to, one, identify that the movement has stopped. And then there should be a continuation of movement on the opposite side for no more than 15 seconds. So what I'm looking for is an asymmetry or no reaction at all. So for example, if I spin you to the left, you stop moving, I should feel a sensation of movement to the right for 15 seconds. But if this sensation continues for a minute and a half, to the right and 15 seconds to the left, there's an imbalance in your vestibular system. And that's what I'm talking about, is if this imbalance is there, rehab will help. I mean, I've done it for years. Rehab will help. But to achieve long-term changes in muscle tone, you must address the nervous system, feet, eyes, which indirectly affects the vestibular system. Otherwise, this imbalance in the vestibular system will continuously create an imbalance in muscle tone and movement and biomechanics and in everything that we're talking about here. So with really simple tests, if I was a coach and I wanted to see if someone had an imbalance, you can do the spin test, as I just described, or you can have an individual do one of two tests, which is basically standing upright, put your feet together, extend your arms, or even arms sideways, close your eyes and see if there's any swing on one side to the other. And this will give anyone a really quick and clear indication if there's an over-solicitation of the vestibular system. And what I would say then is do not train them. Although movement is important and training is important, I'm a big fan of movement. If you are training someone with an imbalance in their muscular system, you are training them into injury. They will get injured. So posture probably is about prevention. I'm a big fan of prevention on every level, whether we're talking about children or athletes or even the elderly, and it must start with the nervous system. This is what I want to say in 2024. So looking at someone's static posture in a standing position, I do look at the shape of the Achilles tendon in the back first to see if there's more of a collapse on one side than the other.
Great.
What's going to spark my curiosity is if it's asymmetrical, which more often than not, it is. So if there's an asymmetry in being flat-footed, for example, or overly supinated, you have to immediately think nervous system. I then couple that with a force plate to have really precise numbers as to my force plate is a one platform, so it's not separate. So it's actually taking into account the full body weight and how the individual is really displaying their body weight on each foot. And I further separate this between the forefoot and the rear foot. So, for example, if I weigh 200 pounds, normally I should have 50 pounds on my toe, on my left toe, 50 on the right, 50 on the back, and 50 on the left, right? And what we'll see is that there's a huge discrepancy between the weight-bearing surfaces.
What about dynamically? So a couple things. I would look at a patient seated. Oftentimes the arch looked fine. And then they would stand and I'm like, oh, where'd that arch go? No more longitudinal arch. And there would be, sort of a collapse inward, let's say. And that's just looking at the way that they would stand. Sometimes we'd see a foot flare, like the right side would, we'd have like, let's say the right foot flaring out. You'd often see there's something going on with the contralateral arm, but that's, a conversation for another time. And then also with gait, I wanted to just talk about gait because this is a really big part. I mean, now we're moving from static into more movement and sort of the movement strategies and the biomechanics and the sort of the articulation and the ability to understand where your joints are in the feet. What are some of the things that we want to evaluate with the feet while they're moving? And gait, being one of the more common, movements that we do with our feet. So what would be some of the things that you would look for as a clinician to indicate that there's some aberrant either mechanics or some aberrant, sensory input that's going up to the brain?
I love to do this. I call it the stepping test, which is also really visual for the patient or the individual. I have them just simply stand up, close their eyes and walking like a soldier on the same spot without moving forward with their arms.
We called that the zombie test. I know exactly what you're talking about. I'd make them put their arms out and then they would like either sway one way or the other. Yeah, we called that the zombie test. It was the zombie apocalypse test.
Zombie test. I love it. I love zombies. The rotation is the direct reflection of the imbalance with the foot. So those weight-bearing surfaces that we can record on a force plate will show dynamically when the individual, when you switch tests and have them do the zombie test, the stepping test, you'll more likely than not notice that there's a rotation on one side. So typically an individual should be able to pass this test and be able to march on the same spot for 30 steps without any rotation.
And this is eyes closed, just for the patient, just for the listener. So you have your either hands at your side, as Annette has said. I used to have them with their arms out, and then we sort of need a bit of a wider space, but eyes closed, and then they would march in place for about 30 or 45 seconds. And sometimes it was it's immediate and almost unsettling for the patient because I had some patients that were 180 degree, like they were facing the other wall, and I'd say, okay, open your eyes, and they didn't know where they were for a second. It was very unsettling for them. So most people, when there was something abnormal, it was like a 45 to 90 degree turn, which is still abnormal. You should be able to march in place, eyes closed without moving, swaying like marching one way or the other. But the 180s, like sometimes I had those 180s and they were like, where am I? Like it was like a jump, like when they opened their eyes, they almost jumped because they weren't expecting not to see the doctor in front of them. The doctor was now behind them.
Yeah, and it absolutely is. It's extremely visual. I find that this is a great test because, as we mentioned at the beginning, people are not aware that they're unbalanced. Unless they catch themselves taking a selfie with a head tilt or whatnot, they're not aware of it. And that's the problem with the brain in that sense, is that the brain is unable to correct itself. It just responds to the sensory input. It cannot correct itself by itself. So this is why if I'm thinking about standing straight constantly, I'm thinking about it, but static posture is controlled by the same parts of the brain that control digestion and heart rate. You cannot control it consciously. You can choose to pick up a glass consciously, but your static posture, the way that you stand without movement, is under the influence of the primitive brain, which is under the influence of, in this example, of the vestibular system, the autolytic system. So this is why interventions that are aimed at addressing all of the sensory components at the same time for an extended period of time. What's that period of time? Ideally 6 weeks. Will always get the fastest results as far as rehabilitation. One thing I noticed clinically, and maybe you can tell me if you've noticed the same, because I know that you look at these different types of sensory entries compared to other rehab professionals, or I want to say commonly as it's taught. I noticed that whenever there's pain, regardless of the pain, there's always an imbalance with the feet and the eyes. Always an imbalance with the sensory receptors, regardless of the issue that I'm being consulted for, regardless of the issue, whatever issue located between the ankle and the head, there is always an imbalance with the feet and the eyes. Have you noticed the same thing, Stephanie?
Always. There was always an issue. And I'll say, especially for women, there was always a problem with their neck. There was always a problem with their head. There was always a head tilt. There was always something going on with the pupils. And then their necks were either, when we would x-ray and sort of look at even just the structure of the neck. So normally when you look at a neck, you should see like a backwards C shape. We would call this like a banana, like a nice, gentle sloping, it's, for the nerds, it's a lordotic curve, for everyone else, it's like, should look like a banana, like a nice, gentle banana. For women, it was either straight or reversed, or we would see like an S shape, like a serpentine shape, so where it had completely become kyphotic. So the neck was like almost, the curve was reversed at the top, like C1 to 3. And then sort of 4-5, we would start to see this transition, and then you sort of get the back of that lordosis at the base of the neck, almost always with women. And I think part of it is women have longer necks, but we also carry, I'd always make the joke, like we carry the weight of the world literally on our shoulders. And so I would find that there would be more aberrant mechanics in the neck for women, even if they came in with, to your point, like if they came in with a hip problem or they came in with a knee problem, I would always evaluate top and bottom. So always looking at the neck, always looking at the feet. And then you have to have the conversation like, I know you're coming in for knee pain, Mrs. Jones, but actually part of it is coming from the aberrant mechanics in your neck or the posture, that sort of unconscious sense that you were talking about as well. So yes, very, very common. And also took some educating with the patient as well, because I think that a lot of times we equate pain locally, like, oh, my shoulder hurts, it must be my shoulder. Right. And of course, we know that there's referred pain, there's radiculopathy, there's visceral referral patterns. Like you could have pain in the left shoulder and actually have a problem with your gallbladder, right? So we know that there's pain that can feel like it's somewhere. A lot of my women would have, like, they think it was like their shoulder, but then I could reproduce the pain rotating their neck or laterally flexing or something with their neck, right? And it's like, well, this is because, and you'd have to go into the whole, education piece. So I think that this conversation, I'm so excited for it, because now this conversation is going to live in eternity on my podcast. And also it serves as an education piece as well. Like, there's some things that you have to sort of undo to get the proper mechanics, to get the proper posture that we're talking about here.
Yeah, and I love what you said about, there's actually clinically, women tend to, the reason I think that it's more women than men will suffer more is, yes, the weight of the world on our shoulders is definitely a component, but this actually causes us to clench our teeth.
Yeah.
Right? And when I say clenching, I'm not talking about clenching while you sleep. I'm talking clenching throughout the day. And if there is teeth contact, constant teeth contact, you'll definitely over solicitate the brain. And, this will create an additional component. Clenching your teeth not only pushes you forward, your head forward, but it also creates a myriad of different events, cascade events or indirect events as far as hormones and stress management. So, something that we have to work at a little bit more, but point being that there is an imbalance with the feet, eyes, jaw at this point, vestibular system. It becomes even more crucial to be able to, one, be aware of it, and then, of course, to be able to intervene to change those asymmetries in the nervous system.
Okay, we're getting into the upper body, but I have a few more questions about the lower body. So let's just shelf this just for 1 second. And then, okay, so you mentioned the force plate, and you mentioned like weight distribution in the foot. So, let's say you're, as you said, you're 200 pounds, you want 100 pounds going through the left foot, 100 pounds going through the right, and then approximately 50% of that going through the forefoot and 50% going to the rear foot. What is your opinion? I was always trying to get people into flat shoes. I find that people wear these sort of bubble wraps as shoes, and if you look at the shoe from the side, you have this like crazy amount of padding. So I'm so happy you brought up the Achilles, because we would have this really thick padding around the heel. And then as you sort of go towards the forefoot, like that padding sort of thins out. Like most trainers, most running shoes, like, I don't mean to call out names, but like a Nike or an Adidas or a Reebok or a New Balance, always very, very thick padding through the heel, and then sort of thins out as we get to the forefoot. And then what that ends up doing is shortening the Achilles, because your heel is elevated relative to the forefoot. Do you agree with that? Can you expand on that? What is your thought on traditional running shoes, on its effect on our weight distribution, that force plate that you were mentioning?
Yeah, well, that will mess the development. So again, depending on where we are on the spectrum, right? If we go back to the way that we were raised, or certainly the way that children are being raised now, typically, if you look at normal evolution of a foot and development of an arch, children should be able to walk barefoot up to 3 years old. In the United States, I know you're in Toronto, in Canada it's different, but in the United States, mothers are required to go back to work 3 months after they have given birth, which means that—
Or if you're an entrepreneur like me, you get no time off. Yeah, Canada or the United States.
Yes. Well, exactly. But I mean, children, they should be able to walk. The moment that you put shoes on, it's going to create a problem. But then to further aggravate this problem, shoe companies, if I may say, without naming any, have decided to now modify this shoe by putting a slight arch support within the shoe, which is then going to, right? So you understand, we see where we're going with this, which is then further going to have an effect on the shoe. So my opinion is, I don't think that when you're an adult, walking barefoot is going to remove a foot imbalance, simply for the fact that the adaptation of the fascial system and the muscular system within the foot cannot be changed simply through barefoot walking. You will be better. There will be improvements. You are improving proprioception. That's why it's probably always better to walk barefoot as opposed to not, but it will not change the foot imbalance. So to intervene, you have to work with, it's almost like you need that 24-hour maintenance in your system. If you really want to change the pressure on your feet, by changing the weight-bearing surfaces. And the only way to change the weight-bearing surfaces is to affect your vestibular system. So again, using methods, feet, eyes together, we use therapeutic insoles, and we can get into that later, how we develop those insoles and how they work specifically on the mechanoreceptors. So instead of inhibiting the information going into the brain, it's stimulating it. So the information, the brain is then picking up on this information, and the descending motor tracts are having a direct impact on your weight bearing through the vestibular system. And we combine that with eye movements and visual exercises to have a greater impact. So barefoot walking, if you had a choice, pick shoes that don't have arches. Best way to stimulate and address a weak foot is to improve proprioception. If you can, get some therapeutic insoles. They don't have to be worn for life. This is a process that needs to be anywhere between 6 weeks to a year, ideally. And then with the therapeutic, if you can't get to the therapeutic insoles, then, try to do some proprioceptive drills as much as you can. And then test your weight bearing. You can do this by putting your feet in water, stepping on a cardboard to see if there's an asymmetry. You can look at your shoes to see if the wear and tear of the shoes are different. And you can see with time how much that progresses. But I typically find that wearing the therapeutic insoles, they basically make you save time. It's having your own personal coach with you 24/7, getting that stimulation 24/7. So you'll get those results much, much faster. So it really is an investment in your health.
So I think this is a good point to talk about them, because where I have changed my mind is the orthotic. So as a chiropractor, we were taught, the companies came in and they're like, you need like everyone's going to supinate, or everyone, you're going to supinate on the left means you're going to pronate on the right. You're going to have pes planus. You're going to have totally flat flea. You need to put the arch back in with an orthotic. And I have completely changed my mind about orthotics, because it's putting in an artificial support on. First of all, there's many arches in the foot. Usually it's just addressing the longitudinal arch, which is what we typically think of the arch in the foot, but we have arches across the metatarsal bed, etc. So we were taught that this is the right way, right? And I'm going to get a lot of chiropractors and chiropodists are going to be, and maybe some physical therapists are going to be furious with me for saying this, but I don't think that they help. I actually think that they are just similar to eyeglasses. They just sort of artificially correct, with an eyeglass, and we'll talk about eyes in a moment. They're just changing the way that the light is refracting to the back of the retina. But as soon as you take the orthotic off, the same patterns reemerge. Now these are not orthotics, and you were very kind enough to send me a pair for me to try on, and maybe you can explain them to me, because they just look like a flat insole, and there's just like a little raised disc at about the midfoot. Tell me what that's doing. Are we trying to reshape the longitude? This is not an orthotic that this insole, correct?
No, not at all.
Yeah.
It's super flat, and it's no greater than 3 millimeters purposely. And basically, in a nutshell, so they improve proprioception through a frequency. And we developed the technology based on different published studies that go way back from different neuroscientists that were trying to understand how mechanoreceptor pressure of the feet could affect postural sways of individuals. And what we know is that the body responds to frequency, heart frequency, brain frequency, ECG, and whatnot. So why not use the language of the nervous system to improve the weight-bearing surfaces of an individual to have that indirect effect on the vestibular system? So what the therapeutic insoles do through a 90 hertz frequency is that they help distribute or redistribute the pressure of the feet more evenly across the foot, providing or affecting stability and helping an individual fight gravity more efficiently. So this is an unconscious process that is going on, because the frequency, it's not like you're going to feel a vibration. It's not electric. It's not electromagnetic, but it also works when you're sitting down. So nowadays, a lot of people are working from home. So having that frequency in your slippers or under your feet are also it travels all the way down, even in your pelvis, to help, with counter the effects of sitting all day long and the poor effects of sitting posture, but they have an effect whether you're standing or sitting. So really what we're doing is we're we're hacking the sensory, the mechanoreceptors in the skin to fool the brain temporarily into thinking or creating those symmetrical motor tracts to have better contraction on both sides of the body, or I should say symmetrical contraction between the flexors, extensors, left side and the right side, which can be picked up and measured through force plate. We know that there's a direct implication with stability. I'd like to also add, if I may, clinically, recently we did a study with state police where we demonstrated just by using the insoles within 3 minutes that we can not only improve blood pressure, but shooting accuracy and grip strength. And there's a video of this on our website, which you can see, where we go through the whole details. And we did those studies with 13 officers, and all 13 of them responded extremely positively with the effects of the therapeutic insoles. And some of these officers were on, taking blood pressure medication because of high blood pressure.
So 90 hertz. So there's a 90 hertz frequency that's stimulating the mechanoreceptors in the midfoot. At least, like that's where it hits, at least in
yes.
Sort of right at the base of maybe just a little bit further rostral than the metatarsals.
Correct, because we can make any individual move unconsciously depending on the frequency that we're emitting. So whether we put it in the back or in the front or on the side, midfoot or rear or the lateral foot, we can literally create postural changes unconsciously. So through this knowledge, we're using frequency to promote better posture and have you just basically uncoil and activate your back muscles so you can stand up straighter. Awesome. And better.
Okay, so let's come back to the eyes. Let's come back to the head. One of the questions on our board exam was the neuroanatomical examination of the eyes, and I still remember the acronym. It was like PERLA. It's like pupils are equal, round, reactive to light, and accommodation. So there you go, board exam people. Still remember it to this day, 20 plus years on. So we're going to talk about head tilt. We're going to talk about the vestibular system a little bit more. Some of my mentors would advocate strongly for just starting with the eyes. And this was really important for, at least clinically, for concussion work. So if someone had been hit in the head, you want to look to see that the pupils are even from left to right, that they're actually that they're first at the same size, that they're round. If they're any other shape other than round, we have, you're sending them to the emergency. If they're able to, if you shine a light in them, we won't get into like sympathetic escape, but someone with a concussion, let's say, if you shine like a phone light, if you put the little light on your phone, on the back of your phone on, the pupil should be able to constrict and hold that constriction. And usually you protect the other eye to make sure that you can sort of evaluate both. But a concussed patient, what I would see is what we call sympathetic escape, where it would initially constrict and then it would blow out. And then we see this huge dilation, like the nervous system was so disorganized, and there was so much inflammation and disorganization that the pupil couldn't hold the constriction. And then the other thing, of course, is like the movement of the eye. So like when you would I would call them pencil push-ups. So like taking a pencil and like bringing it forward, this is like your convergence, right? And then this is your divergence, like bringing the pencil away from you. I would love for you to expand on, I know that I just threw a fire truck, like a fire hose at you in terms of information, but is this something that you look at? Are you looking at like this was one of the first things we looked at was pupil and then head tilt. Like where is the base of the mastoid? Where, like, how is the patient? Like, we would even see this with kids. Like we have kids come in and they would, have like the shoulder and then like the sort of pseudo, like torticollis, we have this sort of pseudo contraction of the SCM and sort of the neck, some of the neck muscles in there as well. So talk to us about pupils and their importance when it comes to sensory information coming in.
Yeah, so pupils being asymmetrical can suggest that there's a disruption with the autonomic system. Clinically, what I look at, I do look at the pupils, but what I see more frequently than not, as opposed to having an asymmetry in pupil size, is the oculomotor muscles, meaning the ability to have the tension of those eye muscles being symmetrical from the left eyeball to the right eyeball.
Yeah,
I do the testing as you just described with the light. Not every single time, but if I use it to figure out if someone's nervous system is overtaxed, because the pupils are a direct reflection of the sympathetic tone. If someone is unable to hold the constriction when a light is being flashed into the eyes, it can potentially suggest that their adrenals are shot and their parasympathetic system is being overtaxed. I use eye movements to help with that. Any eye movements, whether it be vestibulo-ocular, which is coupling the eyes with the head movement, which affects the vestibular system at the same time, vertical eye movements or lateral eye movements, depending on the eye movement that you're going to do, you can target specific parts of the brain. So the connection is really indirect. There's, to say that vertical eye movements will instantly secrete dopamine, it won't, but indirectly, the muscles that are needed in order for your eyeball to move up and down, the origin of those cranial nerves are in the same part of the brain where dopamine is secreted. So can we say that indirectly by using these eye movements, we can have an effect on different hormones? I believe that we can. Can we use light and just pupil constriction to have an effect on the oculomotor nerve, which is going to affect those parts of the brain that affects hormones or sends our ability to calm ourselves? We definitely can. I don't often see someone with an asymmetry in pupil constriction. Maybe you've seen more. I think it's happened, maybe I could count on a handful how many times that has happened. But typically I would refer to an MD if that was the case, because I'm not a doctor myself or an MD. But before doing that, I will certainly try different methods to see and test the nervous system and see even through posture correction if there could be an improvement. Because if you're able to improve the functionality of the brainstem through eye exercises, tame down the parasympathetic system through posture correction, you're having an indirect effect on the parasympathetic system. So if you're able to downregulate that system, maybe you can improve pupil constriction or even eye movements. I know you can definitely improve eye movements because we do it systematically every single time and in less than. And what people will report more than anything is, well, the eyes affects 100% of the brain. So if you have an imbalance with your eye muscles, it will affect your entire brain, all of it. And that's really scary because when you think about it, ultimately what makes us who we are is our hormones and our frontal lobes. So the frontal lobe is what inhibits our limbic system, which is our ability to regulate our emotions. So again, we can talk about this, maybe this would be a talk for another podcast, but yeah, I always use eye movements systematically with foot correction. I actually developed a course called Neurovision to kind of talk about different eye movements to target specific parts of the brain. And this can be applied to anyone. And if anything, what's really cool about it is I think that eye movements should be done regardless of, just as part of your healthy lifestyle. You wake up in the morning, you have your little routine that you do. Well, you should do some eye exercises, and it should be done at least 3 times a day for 30 seconds each time. And you'll notice that if there's pain, regardless of the pain that the person's experiencing, compare pre and post. Shoulder flexion pain, okay, bring your arm up, do some eye exercises and try it again. How do you feel? You're feeling stressed? Great, let's do some eye exercises and see if that can help. And by just using eye exercises, you have an effect indirectly on parasympathetic tone. And you could do the same thing with flashing a light in your eyes.
The up and down movement tracks well, pun intended there, it tracks well with some of the apps that a lot of people spend a lot of time on, right? So when we are on things like Instagram and Facebook and Twitter, like your eyes, you're just scrolling into infinity up and down. And of course, you mentioned dopamine, and dopamine is very closely connected with a lot of things, testosterone, but like the point I was getting at, you mentioned the adrenals, is like the norepinephrine and the epinephrine, or the adrenaline, noradrenaline systems as well. So you are constantly activating when you are always on your phone, just sort of scrolling into like doom scrolling, as they call it. You might see something that's very jarring, like the algorithm isn't stupid. It's like fear porn, right? So it's going to show you something that's terrible, and you're going to start scrolling and looking for more things. And all of a sudden the algorithm's sending you all the things about the Middle East and all the things about the Russian-Ukrainian conflict or whatever it is, right? Whatever socioeconomic or geopolitical whatever is going on. And I like that you said sometimes like your adrenals are shot. And I remember taking a course many, many years ago. And one of the things that really stood out to me, the teacher was saying, at the end of the day or at the beginning of the day, as you had suggested, move your eyes left and right, like to the furthest left, this is parasympathetic in function. So let's talk a little bit about eye movements, because this can get really confusing very quickly. There are different types of eye movements. So there's kind of the jumpy movements. If you watch somebody reading a book, we call these saccadic type movements where the eye looks like it's kind of jumping. And then there's smooth pursuits. So if I'm just like drawing like an infinity, like a side lying 8, you're following that, and the eye can actually move quite smoothly there. And then there's also target practice, right? Where you can like have a dot where you're looking at a dot and then all of a sudden it's over here. So we're looking to see if the eye can actually accurately get to the dot, or if you overshoot, undershoot, etc. What is the value in training, let's say, saccadic movement, and what is the impact that it has on our nervous system and our posture?
Yes, so saccades is going to be more of a reflexive, reactive movement that's going to involve a different part of the brain, the frontal lobe specifically, as opposed to pursuits. So depending, let's say you're an athlete and you want to improve your reaction time, saccades is a great tool to use in order to wake up the brain. There's different eye movements that you can do, whether you're saccading up to the left and looking down and up to the right or sideways. You're going to have a different impact on, again, those different parts of the brain, and that's going to depend on what you're trying to achieve. Vertical eye movements, for example, is linked to a part of your brain that's called the midbrain. And when you're doing vertical eye movements, because you were talking about scrolling, which is like constantly, looking up and down, this is basically what it's doing, is that it's overloading your brain with dopamine. So your baseline dopamine is, as you give dopamine, you're going to end up with a dopamine deficiency because you're constantly moving your eyes up and down. So again, eye movements are not going to directly trigger the release of dopamine, but it will affect those parts of the brain, the midbrain, that's going to have an effect, which is where dopamine is being produced, that will have an effect on the baseline dopamine, which can eventually lead to depression. Moving your eyes sideways, horizontally, will tap in more into the parasympathetic system. It taps into parts of the brain that helps you regulate your stress. It kind of calms you down, so you'll have more of a relaxing effect. And I love to use, I use saccades. I use vertical saccades to wake up the entire brain. If you're doing literally just putting your thumbs like this and you're saccading your eyes up and down, then you are literally waking up the entire brain at that point. So let's say you have an exam and you have to focus.
Without moving your head. So if you guys are trying this at home,
yes.
Here's the cue. You can't move your head. It's just your eyes that are moving.
Yes. And actually, it's a good point that you raised, because if you are moving your head, that would be indicative that there's probably an eye imbalance, right? If you're overcompensating the movement with head movement as opposed to eye movement, then this could be a good sign for anyone that's trying the exercise, that there may be an eye muscle imbalance. So you can use some eye exercises to boost hormones or boost calmness or energy or reaction time. But I always suggest making sure that there's not an asymmetry with the oculomotor muscles first. Because, as in with training, if there's a postural imbalance in your weight training, you're reinforcing the weak and the strong asymmetrically. The same concept goes for eye movements, except you are working out the muscles of your eyes, which is going to be trained asymmetrically.
And I think we read less today. I think maybe you read something on your phone or whatever, but I think that there's more scrolling that's happening than actually taking a paper copy of a book and having that left to right, which is, I like to read at night because it helps me fall asleep. Like, I like what I'm reading, but I also get kind of tired when I'm doing it. So I think that it's an important movement. And I think for, the women that are listening, trying to take an action item out of this conversation, which is so juicy and so robust, and I'm really enjoying. One of the things that you might think about is how can you mentioned like the vertical, so like thumb and you're looking up and looking down as a way to wake up the brain. But maybe you can just like looking from left to right, you can look left, right. And that is a way for you to calm yourself down after a very stressful call, maybe at the end of your child just had a meltdown in the store, you just had a bad day. This is a really nice way to also activate those parasympathetics as well, so that you're not like totally, as you said, like blowing out the adrenals and blowing out your stress response constantly.
Yeah. And we've actually, because I do online consultations where I do promote specific eye exercises depending on the issue that is the reason I'm being consulted for. But to answer your question, Stephanie, I mean, I think that eye exercises is something that's completely untapped. It's something that it's reserved for optometrists, which are only concerned with binocular vision. But I think that any coach or rehab specialist can use eye movements and even use a convergence test to determine if there's a problem with the oculomotor muscles and if doing eye exercises would be justified in a rehabilitation context, which again, if there's pain, if there's injury, there's always most likely, and certainly a concussion, there will always be an imbalance with the eye muscles.
Let's talk about, I lovingly called these pencil push-ups. So we would take the pencil and it would come to, let me just turn it to the.
So I do a saccade. Yeah. I literally, yeah, so I'll position, and I wish I have a pen here. Do I have one? Oh yeah, I do. Here we go. I like to use a regular pen, and I use the tip as opposed to the other side here.
Okay.
And I put it on the nose at the level of the eyes. Right. Mm-hmm. Yeah. And I'm looking away before I bring my eyes together to converge on the tip of the pen.
Okay. So I'm looking at something further out. So right now I'm just looking at my monitor.
Yeah, so you position the pen first at 90 degrees, just like this. You're looking away, right? Mm-hmm. And then you'll actively bring your eyes towards the tip.
Yeah,
okay. Yeah. Mm-hmm. And what you should do is, while you're doing this, have someone in front of you with a phone.
And they can record your eyes.
And you'll take a picture of your eyes, and what you'll see 9 times out of 10 is that one eye is looking away and the other eye is looking at the tip of the pen. So what this indicates is that the brain is receiving 2 different types of images. The right eye in this example is looking at the tip of the pen, and my left eye is looking at the door. So is it the inability
of the left eye to converge?
The muscles, the oculomotor muscles, the rectus lateralis is pulling the eyeball out this side more than the right. So think of a tight hamstring, right? This side is tighter than the right side, so it's preventing my eyeballs from moving inwards and focusing on a specific target. But then take this information and project it to just vision.
Right.
Focusing on something costs energy, right? It goes back to what we were saying at the beginning of the podcast. If you're wasting your energy converging because one eye is constantly pulling you out of balance, your feet are kind of following this, you're realigning your body, you're realigning your eyes. When the afternoon hits, you're exhausted. Yeah. Never having to do the other stuff that you need to do in your life.
Or you're going to hurt yourself squatting, which was me forever. Yeah. Yeah.
Right. So you absolutely want to rectify eye movements pronto, the contraction and the tension of those eye muscles as quickly as possible in order to have an effect. And I'll just take it if I have one more second, because I know we love the technicalities, but an eye muscle imbalance will automatically create an imbalance with the neck muscles.
That was my next question. I was like, let's move a little bit further down. Let's talk about the neck and the jaw. Yeah.
Yeah. So if the tension in your neck is asymmetrical, the way that humans are made is that the spindle in my sternocleidomastoid and my upper trapezius sends very different information to my brain as opposed to the spindles in my bicep. The spindle in my bicep is telling my brain, yeah, you're flexing your bicep, or you're picking up a weight. Okay, that's wonderful. But the spindle in my neck actually communicates with parts of my brain that regulate my sympathetic and my parasympathetic response. It's going to have an effect with tonic postural reflexes, but it's also going to have an effect with the cardiovascular response.
I was going to say heart rate, blood pressure.
Sympathetic tone, heart rate, lungs, stomach, intestines, digestion, vagus, all of that through the eyes. So again, the eyes don't affect the vagus directly, but through a cascade through the sternocleidomastoid, the nucleus intermedius, the tractus, the dorsal vagus. All of those different nuclei are going to be affected because eyes cause an asymmetry of tension with the neck. Now, if you couple that with an imbalance with your jaw, which is a completely other system. So what's the jaw? Well, the jaw is your tongue, your teeth, your temporomandibular joint, and your muscles. But when you're born, you don't have teeth. The teeth are not out. You only have your tongue to eat. And those swallowing patterns, by the way, 2,000 a day, become repetitive. And depending on whether or not a child has the tongue up on their palate and is breastfed, that will affect the development of the arch and the eruption of the teeth. Now, the eruption of the teeth will dictate the position of the temporomandibular joint, which ideally the lower jaw, the upper jaw should cover all of the lower teeth. There should be no crossbite, and there should be no overbite, and there should be no underbite. It all relates to the tongue. It begins with the tongue. When the teeth erupt, it affects the joint. If there's an asymmetry of tension in the joint, it's going to create an imbalance of the muscles of the jaw, masseter, temporalis, medial-lateral pterygoid, and it's going to affect the position of your head, which will push your head forward. 80% of the population has a class 2 occlusion, which is an overbite. That's going to create an asymmetry of tension of the neck muscles. It's going to create an imbalance with your feet. And the loop goes on and on and on. So I can't stress enough the importance of working with a brain-based approach and target all of those sensory entries together to have an effect on muscle tone, on posture, on the proprioceptive system. And when it comes to the jaw, well, we created a device called the functional activator to only and solely help with tongue posture. It's not going to make your teeth grow back. It's not going to change your occlusion, but it will reveal the imbalances of tensions that you have in your teeth. What ends up happening when there's an imbalance with tongue posture is that our tongue, being a muscle, will rest or hinder more on teeth eruption as we're growing up. And very often what you'll see is that the height of the teeth on one side in comparison to the other are asymmetrical, just like the weight bearing on your feet. So if there's an asymmetry, if the height is not the same, the way that the condyle opens every single time you open your mouth, that movement will kind of be asymmetrical every single time. And that's going to overcompensate your entire neck. And you'll feel it. I mean, if you put your hands here and you open your mouth and you hear like a crack and your jaw kind of deviates on one side, then that's the expression of that imbalance. So you do need to work with a dentist up to a certain extent, and then finding a dentist that understands this entire concept is challenging, because in the school of dentistry, they are forced to only look at the jaw. They're not allowed to consider the body as a whole, which is a shame, because posture affects the jaw and the jaw affects posture.
Is this why we're so concerned with tongue tie in babies? Like if a baby's tongue tied?
Well, I mean, I think like braces has become really popular. I mean, the real necessity for a tongue tie, and you're probably going to have negative feedback from what I'm going to say here, but I don't think is necessary every single time. I think that probably one time out of 10, there will be.
I do think it's overdone. I do think that I remember my midwife is like, I think there's a tongue tie here. And I'm like, I don't think so. He's latching fine. He's like getting he's good. But I think that there's a clinic in Toronto that doesn't matter what the name is, but like all they do is tongue tie. Like they've opened up a clinic just to do tongue tie. And it's like, well, and maybe this is just my suspicion, this could be completely wrong, but it's like, what is the likelihood if your entire clinic is based on finding tongue ties that you are going to find a tongue tie? It's probably higher than what is naturally occurring in the population.
Well, I think it's just like orthodontics. I think it's something that has now emerged and is growing. But you know, I've heard a lot of cases of what is it called? I never know how to pronounce it. The frenectomy on effects on posture. I mean, in this moment, you will have an immediate release because obviously the tongue is attached to the fascial system. But as in with any treatment, if there's an imbalance in other systems and you just release one without considering the system as a whole,
Right.
repercussions will happen elsewhere.
Mm-hmm.
So, the importance is that we understand the side effects, and it's going to be, a cause and effect. Is it going to be more beneficial for the parent to do a tongue tie in this instance? And if you do choose to do it, make sure that you're well informed about the risks and the side effects, and hopefully, your justifications of why to do this will be justified from a postural standpoint.
And what is ideal tongue posture? Where should the tongue be sitting in the mouth?
So the hard part of the tongue should be up on the palate. So when your tongue is out, it shouldn't touch your teeth. Mm-hmm. There should be no teeth contact. So one test that adults can do, even with their kids or even with their children, to find out if that system, that oral system, is developing well, is when you close your teeth, if you just slightly bring the lips down and have the child, teeth closed, swallow their saliva. If you see this, I'm going to show you the problematic, what you don't want to see is this.
Oh, the teeth come forward, or the tongue comes forward. Yeah.
Yeah. Or that.
Mm-hmm.
So this is a lingual propulsion. Every single time the child is swallowing their saliva, they are pushing on their teeth.
And years of that, you're going to have deformed teeth over time. The teeth are going to sort of come outwards. Yeah.
And what's happening? Well, you're going straight into braces, and what are they going to do? They're going to pull teeth out, healthy teeth out, to shrink the jaw. And once the jaw is shrunk and the arcade is forever modified, never mind having to keep this on for 2-3 years, then they will put a little lingual, whatchamacallit, wire, to make sure the teeth stays in place. The problem with that scenario is, in order to have physiological nasal breathing, you need space. If I shrink the jaw and your tongue has nowhere to fit, if you have a lack of space, is because you have poor tongue posture. Your tongue is sitting low as opposed to sitting up. So that's the cause. That is the cause. And again, that's another topic for another day. No one ever talks about, and we can start really right from birth. Breastfeeding is the only thing that will combat this. Obviously, food, you don't want to have any food allergies because that will block the sinuses. This is obvious. So this is something that needs to be addressed as well, what the mother's eating and what the child is eating as well. But there's a lot of things that could be done, and prevention is something that's at the forefront of Posture Pro. We want to prevent any issues as best as possible to avoid the need for all of these different methods that are eventually affecting posture.
I always was at odds with this idea that we had to take out teeth. Your molars, we're going to take out they're coming in, we're going to take them out. Why? Why do we have to take, maybe this is my naivete, and certainly I'm open to somebody explaining to me why, but I don't feel like we would have evolved to have this many teeth if they weren't necessary. It's not like we have teeth on our shoulders and teeth on our elbows and teeth coming off of our cheeks, like places that are not necessary. The reason why we have the molars that we do is for chewing. I mean, from a teleologic perspective, you can say before fire, there was a lot of chewing, a lot of mastication, and, therefore we needed, these strong teeth to sort of rip apart and mash up the food so that you can sort of mechanically digest it prior to the chemical digestion. And you sort of look today and everything's soft, like we have soft fit, like we're not really chewing a lot of foods. There's like smoothies everywhere, and not that smoothies are bad, but everything is soft and overcooked, right? So I always had a problem with this idea of removing teeth. And I'm so happy that you talked about nasal breathing, because my big question here is what is the relationship that you see clinically between poor tongue posture, shrinking the jaws we've been talking about, and having an impact on nasal breathing, being a nasal breather versus being a mouth breather?
When we have proper tongue posture, the intake of air will be filtrated through our nose, which there's a direct relationship between what we breathe and the brain-gut axes, as you know, and being able to filter out all of these different pathogens when we breathe through the nose is super important for our health, not just our gut health, but just, our ability to just intake air and the good quality of air. And I just find that you said something just before that sparked the thought in my mind is the real reason why teeth are being pulled out is because it takes more time for a dentist to clean the teeth in a regular cleaning if the wisdom teeth are still in the mouth. Okay, so I'm going to repeat that. It takes more time on the chair for a dentist to clean the teeth if they have to go all the way in the back and clean your wisdom teeth. So it's easier to just pull them out. So before we move on to how else.
That's an infuriating thought.
Infuriating. So just saying it to you, I had to kind of sweating. It is extremely infuriating, and there's could be many side effects from that. But then mechanically, you are changing the shape of, you're forever changing the shape and the mechanics of your jaw. So you must understand this. Now, if the back teeth, as you were saying, are there for a reason from an evolutionary perspective, they are there to anchor the condyle and the fossa, your joint, your temporomandibular joint, right? So now if I'm removing the ground, I'm removing it for cleaning purposes so I can put more clients or more patients on my chair. So it's going to cost me less time. I'm forever changing the mechanics of the jaw. Well, the development of that jaw mechanically is changed forever. So your tongue may be compromised just because of that, because you're going to kind of move your head forward to grasp air. If the jaw is pulled back, right, in its proper position, you have proper cervical spine, you're able to intake air. Now, moving along to children, I think there was a study done on, prevention does start with the children, so I must say something about that. I do have 2 kids, and for me, it was super important, and super important for any mother that has a child to know this. There's a study done on 11,000 children over a period of 7 years, which demonstrated that children who snored were mouth breathers, as we know, and this would be associated to ADD. The study demonstrated that ADD, learning disabilities, are directly linked to mouth breathing. So the reason I mention this is because, I know a lot of children that are currently on medication for ADD and just concentration. Isn't it nice to know that there's a direct correlation study done over 7 years, 11,000 children who are all mouth breathers, which is linked to ADD. So that's just, just a little, a little bracket that I wanted to mention there. Pulling teeth out is a problem in that sense. And the best thing that we can do is promote tongue posture and make sure that chewing gum is awesome for children, by the way. And I think
chewing gum, that's a good tip. Oh,
for children.
Okay.
What I would do to promote even proper tongue posture is, how you have them form a little ball, like you make the chewing gum in a circle, right up on the palate. And then you tell them, honey, just flatten the gum out, like open it up with your tongue as much as you.
Oh, that's so smart.
Yeah. And I give my kids gum. Obviously, I have the good gum. I give them the harder the gum, the better, because as with the foods and the processed foods and the fact that our food is no longer hard, and, the evolution of food is a problem. So the harder the gum, those tasteless gums that you can get in Europe that have no sugar in it, it's like literally you're just chewing on a piece of plastic. The harder the gum, the better.
It's like a toothpick. It's like it's just there. It's like it has no taste.
It has no taste, but it's awesome. They love it. I just stuff it in their mouth and I just have them chew for hours on end, and then they just get so this is actually working out their muscles. It's forcing proper tongue posture. It's creating symmetry. It's helping the teeth erupt properly, because through chewing, this is how you form your teeth.
That is so good. Okay, so there are women listening who have children that are now rushing to buy gum, which is awesome. But what if those women themselves have had their wisdom teeth taken out? They're having trouble, or their husbands are having trouble, men or women having trouble nose breathing overnight. Is there any hope or is it just, you've passed this sort of point of no return and you can't actually change the tongue posture, you can't actually change the shape and the mechanics of the jaw?
There's always hope. Thank God. Yes, there is hope. And the answer lies in buying a mouth guard, a functional device that will specifically address tongue posture. So we created one because it didn't exist at the time. And we created a mouth guard that is called a functional activator. And it's basically a mouth guard that looks like kind of like a double gutter mouth guard that permits these, when you put it in your mouth, it permits these micro movements. The production of saliva will increase. You'll find yourself kind of mini clenching into it. And what that's doing is that it's basically resetting your temporomandibular joint by forcing you to position, gently forcing you, but very actively forcing you to position your tongue on your palate. It's a very active device. If you're a mouth breather, it might be a challenge for you at first to sleep with it. And I would actually strongly suggest just wearing it throughout the day when you're working on the computer, when you're training, when you're watching a movie at first, when you're meditating. Just take a moment and feel your jaw and your tongue and focus on your breathing and your swallowing patterns with the activator in your mouth. And this device basically helps. It's a lifesaver for anyone that snores when they're able to sleep with it, because it forces the person to put their tongue on their palate. Now, one of the comments that we get is when I put it in my mouth, my lips are kind of open. Well, the orbicularis is a muscle that's located right around your lips, and you should be able to have your lips closed around it. And this is actually a muscle that we practice with children. I'm switching topics here because I want to give so much information. The orbicularis muscle needs to be strong in adults and children. And you can train it. It's free. You can grab a button, like the button of your jacket, and you put like kind of like the string on it. I wish I had it here to show you. And I have the child kind of like put it in their mouth. So it's like this. You put it in your mouth and they're kind of hold it.
Yeah.
And you pull it out and you kind of practice that to strengthen the orbicularis. When you have a strong orbicularis, all this to say, you're able to keep your lips closed on the functional activator. So if you get this device and you find that your lips are open and you're aggravated because you can't close your lips, it simply means that the orbicularis is weak, which it should not be.
Which it will get better with time the more you wear this, I would assume, right? Because you're trying to close your mouth over the activator.
And hence the importance to begin slowly at first.
Is this for kids? Can you put this with kids as well, this functional activator, like for smaller jaws?
Yes. So we do have 3 sizes, and I would recommend starting at the age of 3 years old, not before. And what I would do with my kids is I would go in when they were sleeping. I would just slip it in their mouth. They're sleeping, kind of tickle them, and they're like in their half sleep, half awake. I just stick it in, and you'll see right away, boom, they latch onto it. They immediately clench, lips are closed, and they sleep. And I'm like, now I feel now my job.
The mom in me can relax. The mom in me can relax. Yeah, I love that.
No, it's a great device. It's really, you want to create space. The more space a child has in their mouth, the more space they will have in their future in their lives. The jaw is directly linked to possibilities in the brain.
And if I may add, I know I've been talking about squats. It's going to help your squats.
It's also going to help your squat. Yes, that's an important thing.
I know. And I always bring it back here because in clinic, I always had a really hard time sort of dialing down the importance of this postural, this brain-based approach, what we've been talking about over the last 90 minutes. And, I've sort of found myself saying, listen, you're going to get, for me, I was wearing these big clunky shoes, didn't have really good articulation in my feet. Would always predictably, I would reach a certain weight in squatting and boom, I'd throw out my knee or my hip, my iliopsoas, something would go. And I really had to unlearn. I had to unlearn all the motor, all the sort of movement, all the motor mechanics. So as I mentioned, you were very kind to send over these insoles. I've been wearing them and I find they're just things are just a little less achy. I feel like I'm always a bit of a postural nut anyway, but I just really, really like them. And I think for anybody who is trying to make sense of like what's the takeaway here from this conversation. It's that this is the foundation for everything. It's going to be the foundation for your ability to rest and recover. It's going to be your reaction time and your ability to squat or lunge or pull-ups or whatever it is, and avoid injury. And I think that for, I was saying to you before we started going, like we got perimenopausal and menopausal women in the chat, right? Like they are listening to this conversation. And one of the fundamental principles when you're moving in your 40s, 50s, 60s and beyond is to avoid getting injured, because we simply cannot afford the time off to nurse the injury, like the degradation that happens in the muscle tissue and the skeletal tissue and the joints and the cartilage, all that happens when you are inactive because you've hurt yourself is far worse in your 50s than it is in your 20s. So I think that what we're talking about here all relates to globally injury prevention, but also you're going to squat better. You're going to be able to do pull-ups. You're going to be able to, because pull-ups it's a combination of strength, mobility, flexibility, and of course, spatial awareness. Like where are your scaps? Where's your scapula? We didn't even talk about that. But so I won't throw in a new conversation at the end of our time together, but just sort of wrapping this in the bow. Like this is why this is so important. It's it's like you wouldn't put furniture, if you were building a house, like you wouldn't start with the furniture. Like you'd start with the foundation. You'd start with the concrete and start with the, I don't know anything about construction, so this example is going to go bad really quickly, but you're going to start with the foundation of the house, the walls, the floors, right? Before you put in the rugs and the lamps and the paintings.
And you'll increase your longevity. I mean, after all, this is what it's all about, is aging gracefully and without pain, enjoying our lives and being able to be there for our children as we age. So if there is something that you can do to increase your longevity that's so simple, like having your own personal coach with you under your feet, applying some eye exercises, it's going to cost you a minute and a half per day. If you can get the functional activator or wearing it when you're training, will actually increase your VO2 max. So you'll increase the oxygenation into your body. And just simply by being better aligned and not wasting all that energy standing upright, you'll have more energy for just your bodily function, for your daily life, which will indirectly affect your cortisol production, your inflammation in the body. Inflammation creates cortisol, so you'll decrease your cortisol level. And as women enter menopause, the symptoms of menopause are doubled when there's high cortisol and adrenal fatigue, right? With the testing that we did, if we're unable to hold the pupil contraction, we know there is adrenal fatigue. Menopause might be really hard for some women to go through. So all this to say that better posture just increases your longevity on the entire spectrum and just helps with absolutely everything. And this is true for women and men and children.
Yeah. Yeah, I think the next time you're on the show, we're gonna do a deep dive into children. I had wanted to talk about primitive reflexes. We didn't get to that, but we'll talk about it next time. You've been so kind to offer our listeners a discount, I believe, anything on your store. So we're gonna link out to the Posture Pro store. I believe the code is BETTER15, and that gives you 15% off of anything in your cart, anything in the store. Very, very generous of you. So why don't you, with that sort of, I just plugged it for you, but, plug where can people find you? I know you also mentioned courses as well. So it's not just products. There's also courses that you also offer for clinicians and anybody who's interested in learning more about this stuff. Yeah.
Absolutely. So the main website is posturepro.co, which will link you to either our education if you're looking to learn online, or if you're looking to buy some products to fix your posture, it will link you to our shop. And shop.posturepro.co is for the products. Education.posturepro.co is for the education format. And you will also find us on all of our social media platform, which is Posture Pro.
Awesome. All those will be clickable links in the show notes. Annette, I cannot tell you how much I've enjoyed talking to you today. Like, I don't know if it's obvious, but I'm like, we're going to nerd out and it's going to be all about neuroanatomy. Yay. So thank you. Thank you so much.
Thank you. Thank you so much. What a great way to start the week. So thank you very much for the opportunity. It was an absolute pleasure. And I certainly hope your listeners enjoy it.
Me too. Thank you so much.